Okay, this is ADHD objection handler part 4B, and the last of these that I will be doing. I'm going to be starting a new channel that's devoted more to ADHD stuff, and I will be returning to MBTI themed stuff specifically for this channel, which is its intended purpose. I do have a video to make that combines the two that's coming up after this one. But after that, I have a backlog of non-ADHD related MBTI stuff that I've had on the back burner ready to be made and posted. So we'll be getting to that stuff. All right, so I should start with my disclaimer and say again that I am just a layperson who is uncommonly informed about ADHD, but I do not have any medical expertise, nor am I licensed as a practitioner in the mental health field or the medical field. So, so please take what I'm saying as an opinion piece, and by all means check my sources. And for this one, what I'm going to be doing is carrying on talking about some specifics that might help some people differentiate ADHD from other disorders that with attentional symptoms may mimic ADHD. As I said in part 4A, it is more the norm than not that adults that have, and children too, that have ADHD, that they have other comorbidities. They have other mental health issues going on, or they have learning disabilities going on as well. So that can make a much more complicated picture for a clinician trying to sort things out for that person and try to figure out, which disorders are causing which symptoms and to which degree, so that then they can make an effective plan of treatment for that person to help them. But just because it's complicated doesn't mean that it's not something that should be done. And people should not be giving up on looking into whether ADHD could be a contributing factor in patients, clients where there is indication, where that client is bringing to you problems that could be related to ADHD. Those should be investigated, and they should be investigated thoroughly, because we do know that the vast majority of it, especially of adults and girls with ADHD, are not getting seen at all. Their ADHD is not being recognized. It's not getting treated, and it's really wreaking havoc with those people's lives. And there are things that can be done. There's a lot that can be done to help people with this disorder. So it's well worth looking into. Now, the document I'm going to be referring to for this part is the Canadian ADHD Resource Alliance's, CADRA, as it's usually called. It's CADRA's Practice Guidelines, the 3rd edition. It came out in 2011. There hasn't been another one since. So that's pretty old, but I believe that the material that's in there would, at least most of it, if not all of it, would stand today. And though these are not consensus guidelines, these are guidelines put together with a consortium of clinical experts in ADHD. So it's not a Mickey Mouse document. It's I showed it to a friend of mine who came this close to finishing her residency in psychiatry, and she was very impressed with what she found in there, with the extensive amount of information, and it's very well written, very well organized, and very easy for referencing for clinicians. So I'm going to just read a few entries from a particularly, I think, a really useful chart that any clinician or anyone interested in this really, from a mental health perspective, would be interested in, or very well could be interested in. It's from chapter 2 of the CADRA Practice Guidelines, and section 1, page 19 of the free downloadable PDF, which you can get from the CADRA site very easily. What's also cool is they've organized it on the CADRA site so that if you're just interested in a particular topic that's in the clinical guidelines, you can download by chapter. So you can just get sections of the whole big fat thing to keep for yourself if that's what you want. So in there's a very handy chart to help clinicians with differential diagnoses. And what the chart does is it has in the left column a bunch of disorders that can mimic ADHD. I believe what they mean by mimic is specifically those that can mimic the attentional symptoms of ADHD, the symptoms of inattention. Because I have heard from Russell Barkley that all the mental disorder, who's a professor of psychiatry as well as a clinical psychologist and researcher and blah blah blah, foremost expert in ADHD, that all of the mental disorders can present with symptoms of inattention, difficulty focusing, difficulty retaining information and putting one's focus where one wants it to go. So this chart is to remind clinicians of certain key features that are of these potentially mimicking disorders that are not features of ADHD. And it's I assume that's to help clinicians, infer from that if they have a client who's coming in and talking about difficulties in something, and they do have attentional features, and let's say this client also has a known pre-existing condition or more, this is to prevent clinicians from just going, oh yeah, like whatever that other symptom is that you're having trouble with. I'm sure it's because of your whatever we already know about. This is to help clinicians sort of infer, like, oh, okay, well if they're presenting, for example, something that really can distinguish ADHD clients, their problems that owe to the ADHD rather than to another coexisting disorder are ones that have to do with dysregulation that indicate executive functioning deficit, cognitive deficit. So, switching attention, or in the largest sense, as I've gone into in my other videos, a bit more, and the authoritative sources on this matter go into way, way, way more, such as Barkley, for example, in his lectures. The sort of behaviors that help one self-organize their behavior towards obtaining midterm and long-term goals that will be very important to that person's welfare. Executive functioning deficits are those that get in the way of that and that prevent that and that cause dysfunction in the normal developmental level abilities to do that. And all right, so I'm going to go look at this chart. I'm going to read a few of the things from it. Cadre guidelines. Okay. So, for example, they have here generalized anxiety disorder that can mimic some ADHD symptoms per the DSM. But here are some features of GAD that are not characteristic of ADHD. Worry for 6 months or more that the person cannot control, lack of energy, anxious mood, and somatic anxiety symptoms. So, what else? So again, if you can use, maybe a clinician can use this as an inference. So maybe if a patient is showing, this and this and this that is characteristic of ADHD, and they report being very, very anxious, but they don't have, and it's, it's something that's really bothering them, but they don't have somatic anxiety symptoms. Again, it doesn't mean that the ADHD is the culprit, but it might indicate to a clinician, maybe you should pay, if there are other things in evidence, maybe you should do an assessment for ADHD as well and see if the person qualifies. Okay, another one. Major depression can mimic ADHD sometimes. And here are symptoms and signs of it not characteristic of ADHD. Episodic decline in mood or depressed mood and or dysphoria, suicide-related issues, low energy, psychomotor retardation. And this is me speaking, just sort of anecdotally off to the side. Dysthymia is what I learned in some workshops I've attended intended for psychotherapists and practitioners in mental health. What I learned is that chronic dysthymia very much more often goes with ADHD than does major depression, although there is a significant subset of patients who have major depression who also have ADHD. So that's where that, the psychomotor retardation, these are features of very severe depression. And dysthymia is more likely it's more often coexisting with ADHD than major depression is. Bipolar disorder 1 or 2, manic or hypomanic phase. Sometimes ADHD people get misdiagnosed as being manic, when really what they are is, high energy that naturally goes with those who have the so-called combined type ADHD, where the hyperactive component is still evident in how they speak, how they act to an extent. It diminishes in adulthood. It's not nearly as noticeable in the vast majority of people, adults with ADHD, but you know, people like me have a lot of high energy, obviously, and speak quickly and so on. That can catch people's eye. All right, symptoms or signs not characteristic of ADHD and bipolar, 1 or 2. Episodic change from baseline, psychotic symptoms. Again, ADHD is not characterized by that at all. Grandiosity, no. Pressured speech, recent decreased need for sleep. What else do we have here? Learning disorder, and it says indicated symptoms or signs not characteristic of ADHD. Consultation with psychologist or neuropsychologist confirms presence of the disorder. So, you know, it gives clinicians some, you know, something to go on. Autism spectrum disorder has some features that can mimic ADHD, but here are what's specific to autism spectrum disorders that is not specific to ADHD at all. Qualitative impairment in social interactions, communication, or odd eccentric behaviors. That's pretty vague, isn't it? Anyway, sorry. Side note. Editorial, not part of the guidelines. Okay, then for an example of a general medical condition in this chart, this really useful chart, I think, one they have under there is head trauma or concussion, and then the column to the right, investigations confirm the diagnosis of the medical condition. It says, this is a good point, since underlying ADHD can increase the risk for head trauma, it's important to look for the timing of cognitive symptoms apparition. Were they present before, or did they appear or worsen after the head trauma? If you're trying to sort that out, you know, the look-alike there. So anyway, on and on. There are many, many, many more conditions. I'll not bore you to death by reading more of them, but this is just an excellent source of information for clinicians if they'd like some help and some guidance in identifying what is the ADHD and what is not going on with such and such a client or a patient. And with that, I have one more, maybe just 2 more videos that involve ADHD stuff, and then I'm going to stop it for this channel. And one of them involves MBTI stuff as well. So if you're interested in that, stay tuned, and I will have that up pretty soon. Thank you for joining me.